Welcome to this episode of Pondering Play and Therapy with me, Julie, and this week my special guest, Joanna Blundell Jones. And Joanna, I believe you're in Sheffield. Tell me about your day, the weather, what's happening in Sheffield today?
Today, I think, like a lot of the country, fantastically, we have blue sky and sunshine across Yorkshire. Yeah, so it's lovely to look out into the garden and see blue sky. Yeah, very much enjoying that. And today is a day where I'm doing Theraplay-based stuff at home, having dropped my daughter at school, and my littlest is off at Forest School.
Yeah, you have two
For me.
little ones. Oh, Forest
Yeah.
School today. It's your little boy, isn't it? At Forest School. Yeah, he's going to be having a wonderful time today.
Yeah.
Thinking about the reason we're having this conversation today is you work, as you said, as a Theraplay practitioner. You're also a clinical psychologist, I understand, and you do lots of other things. And mainly what we're going to be talking about is your work in a hospital setting for the NHS.
Yeah.
But before we get started, I just wanted to get a sense, and this is something I ask everybody, is play and adults. What plays in your life? Not necessarily play with children, but how do you see play happening in your life or in your workplace?
Good question. I don't know whether it fits in. I think it does in play, is singing. I'm a part of a gospel choir.
Are you?
Yeah, Sheffield Community Gospel Choir. And yeah, that is one of the best parts of my week, going to rehearsal and singing and having our performances whenever they come up. Yeah, so that's a big part of play. I think when we have the time in an evening, more likely to be like a holiday-ish time, Tim and I, and particularly if we've got guests around, might get out a board game. So that might be something like Istanbul or Settlers of Catan or Carcassonne. They're kind of like family favourites. Yeah, I think they're like my main play. And at work, I would say it's not how my brain works, but I love being a witness to it. Some of my colleagues are so good at puns. So we have a WhatsApp chat and people post various things on. And then some people come out with, I'm like, what? How's your brain done that? It's just incredible. So I can just admire that playfulness that they have on the chat or in the office if there's kind of banter and kind of encouragement going on.
Play.
Yeah.
Yeah, playing with words, playing with friends, playing with board games. And that concept of singing as part of play. We talk about playing music. We talk about playing sound when we're singing, but absolutely all part of that.
Yeah.
So I'm really glad that play is part of your life. And of course, you have two little ones, so I can imagine they do a lot of play.
Yes.
And you get to do a lot of play with them.
Yeah.
Yeah. You're on the floor quite a bit.
Yeah. They're at an age now where they do they don't need so much, let's play this, that they come up with something and then they'll play happily for a bit and then come and join in. And it's lovely seeing their little minds come up with different ideas of things to play.
So they don't need you to facilitate it so much. Yeah. So say, let's do this.
Yeah.
So a lot of play in your week. Like lots of people, you're also working as well as being a parent, a partner, a friend, a family member, a gospel choir singer. Like lots of us, we're earning our living playing, which is often sort of eyebrows raised sometimes when I say I'm a play therapist. I often get, oh, that's nice. Is that really a proper job?
Really?
Whereas you have the title of clinical psychologist, and I expect nobody's ever said to you, is that a proper job?
Yes. No, I think, interestingly, less so now, but certainly when I first said it, people were like, oh, can you read my mind then? Interestingly, I guess society's moved on. I don't get that reaction now. I'm like, yeah, no, I can't read minds and I'm not a psychoanalyst. I'm
Well,
quite
even then, you...
even then you can't read minds. But I think there's a lot of mystery surrounding some psychological therapies that kind of puts people a bit.
Yeah, and then somehow my experience is as soon as I add the word play into my title or my job description, quite often I've seen my role diminished or my qualification questioned, or a sense of I'm just playing or I'm teaching children to play because I'm a play therapist. So I think there's lots to be thought about in our titles. But in your role in the hospital, is this, which hospital are you at, Jo?
So I'm at Sheffield Children's Hospital, and I have been there this June 13 years, which kind of feels bonkers. It doesn't feel that long, really. When I first started, I was also working in CAMS at the same time. I had 2 part-time jobs. And then, after maybe 5 years-ish, I stopped my CAMS job and just did my pediatrics job in the hospital.
And that would be quite common, I think, in the UK for therapists, psychologists to hold several jobs and have their week made up of different roles in different settings. I think
Can be, yeah. Yeah, some people will have a full-time post somewhere and do that. And I was very clear that I wanted to do part-time. This job was originally like a 2 days, and I was like, oh, I think I'd like to work more in a week than 2 days, which is then when I got my CAMS job. Yeah, but I think within my service at present, because there's a whole team of us in paediatric psychology, there are a number, I don't know the percentage, but a large number of people work in more than one medical specialty. So within their job, they've got lots of jobs.
Lots of jobs within it. So what's the medical speciality that you work with then within the children's hospital, or do you have that?
Yeah, so I am on the cancer ward, so in oncology and hematology, and we do now have a little bit of funding money into what's called hemoglobinopathies, which covers sickle cell and thalassemias and things. So non-malignant blood stuff.
So give us a sense of who your patients are. Are they mainly, you mentioned the ward, are they mainly inpatients on the ward, or is it an outpatient service? Yeah, just give us a sense of how your week might go.
Yeah.
Who your patients might be.
We are within, so there's a number of us in the little psychology oncology team. And we are 0 to 25 officially in terms of the patients with the diagnosis, because we work at the children's hospital, but we feed into the adult hospital where 16 plus are treated. And because there's recognition that actually there are different needs for for adolescents and young adults. So there's a specific team of clinical nurse specialists, social workers, and youth support coordinators, as well as then us psychology for the 16 to 25s in the adult hospital. In the children's hospital, we're 0 to 18, and we basically will take a referral at any point in their cancer experiences. So it might be at diagnosis or like during like the beginning stages when perhaps they're getting used to treatment and they're inpatient a lot. But probably, again, I don't know what the percentages are, but I'd say the majority of the work is after treatment. Okay. So not much at diagnosis, but quite a large chunk during treatment, and then a larger chunk at the end of treatment. And we're quite blessed as a service in that we're not really restricted in the number of sessions that we offer or at the point at which we see somebody. I have seen young people before who had cancer as a kid and then have come back as a teenager going, this happened. Well, this happened to me. I had cancer. I need some space to think about what that means for me and work through perhaps some memories and things. Yeah, so we might see them at any point in their experiences. And also we are open to seeing siblings or other family
I
members,
wondered, yeah.
depending on how much demand there is from the children who are have experienced cancer themselves. So that kind of varies as how able we are to offer that, I'd say.
And that's really interesting, that sense of an open door, no restriction to the pathways or the number of sessions. And I wonder how that compares to your experience of working in CAMS.
Totally different.
You're laughing. We're laughing, but it's like, it is so different.
Yeah.
Where you'd have a set pathway, set number of sessions. And when you were working in CAMS, was the cutoff 18?
Yeah, the cutoff was then. And I think if we looked at the other medical specialties within like my pediatric psychology service, they will have different criteria as to, so some, because Sheffield Children's Hospital is I can't remember what the official term is, but it's a regional centre for children to get their treatments. So they might come from Lincolnshire. People will actually come up from Nottingham for certain things, from the whole of South Yorkshire and the surrounding areas. So we will take people from all over, whereas other services, they're only for Sheffield children, or they're only for children whilst they're an inpatient. And then there is, so I'd say we're unusual. Like not all the medical specialties, have that same capacity to be as open as we are.
Yeah. And say if you're working with a child or a young person on the ward, they're actually physically in the children's hospital for treatment.
Yeah.
What might be the work that you're doing with them? How might play therapy, your psychology skills, your theraplay skills come in? Be really interested to hear.
Yeah, I think when they're inpatient and in the throes of it, it is a very different sort of work than when they're not in hospital, when actually treatment is mostly done. A lot of the time it's what we would talk about as containment, as getting through, as you're not processing the stuff that comes after. It's just, how do we get you through this? There was a lovely piece of work, it's quite a number of years ago now because she's now a teenager, that had a real privilege of supporting a family who had a really long-term stay in hospital following complications of treatment and things. And I did theraplay with her and her dad. And we did like formal theraplay, but in the hospital, in her little cubicle. And that was just, wonderful to be able to support them in that way during the time that they were stuck in hospital and unable to go home, and to see the impact of that and the relationship between the daughter and the father and the changes that kind of came on there and in how she was generally in the hospital as well.
Yeah, so using play to maintain a relationship, to maintain and develop connection with the supporting parent, but managing to do that within the hospital cubicle. And yeah. And Jo, do you have, this is another term, play specialists?
Yes.
Could you just take us through what's the difference between what you do as a clinical psychologist, or what I might do as a play therapist, and what a hospital play specialist does? Because they're often seen as the same. I'm sure there's huge overlaps, but what's the role of the play specialist?
Yeah. So we've got them in a number of places within the hospital, and we've got a number on our ward. And one who very recently has got funded by Anthony Nolan, which is a charity looking at bone marrow transplants. And she is the first funded play specialist for bone marrow transplant, which is very exciting. Although her role is in the run up to transplant and then community after, rather than the hospital inpatient bit, which is where the normal team of play specialists do stuff. And play specialists, they're not mental health professionals.
No.
So that's the key difference.
Okay.
But obviously they do have an impact, and the whole point is that they have an impact on a child's well-being whilst they're in hospital.
Yeah. Yeah.
And there is a course that they do in order to get a qualification in being in a play specialist. We had a lodger once who was doing that, interestingly. So as I see their role within our hospital, within my ward, it's to help children cope with the demands of going through treatment through helping them be engaged and interested in stuff. And it's not babysitting. It's not just like filling their time, but it's being aware that play is really important, and so they will have dedicated time. If a child is an inpatient, particularly for a period of time, the play specialist will be aiming to go in every day or at least every other day to give that child a dedicated half an hour with them to do something specific. And they've got a whole playroom of stuff which they can bring into the child's cubicle if they're not allowed out of their cubicle for infection control purposes, or the kids come out of their bed space and into the playroom and just have free play time in there. If you spoke to a play specialist, they'd be far more
I was thinking that's
in the explanation.
Maybe we need to interview your play specialist to hear about his or her experiences, because one of the things I'm thinking as you're speaking is the role of the play specialist or whoever's actually working with your child to distract the child from what's happening and what's going on, to give them a bit of emotional respite and, in inverted commas, to just play? Or is it to help prepare them to accept some of the, I'm sure, very distressing procedures that are going to come their way while they're in the hospital? And is it a mix of those? And
and that's the other main bit. And I don't know how our play specialist team would say that their time is divided amongst those. But a massive part of their role is preparing kids for procedures, helping them to understand what's going to happen. So they have various different props and toys that they can use. So like bears with what are called wigglies, which are the kind of the central line that kids often receive their chemo and blood and whatever through. So in a fun way, they're called wigglies. So bears with wigglies and wiggly bags and with nasogastric tubes and all sorts that they can use to help make things not so scary. And depending on the child, it will depend on how much preparation work that they might do for something. If they go up to have radiotherapy, then the play specialist team will support them with that, of doing visits to go and see it, because that's it's in the adult hospital. So they will support them in going up there. And so there's a large chunk of work that they do with preparation.
And something a while ago, you and I were at a Theraplay conference or a day conference. Can't remember when it was. It was sometime last year. And
June last year.
It was it? Gosh. And you were describing some of your work, and you very kindly showed us some videos of working with a client who was going to go through some sort of scanning procedure. I think he was with his dad, possibly. And you use Theraplay, I think, to help prepare him or help him understand or tolerate the lying still. But I might have got that all completely wrong. But can you tell us a little bit about that work you did with that family?
So I get there might be two, because I guess we talked the other week, didn't we? There might be two slightly different stories being interwoven there.
That happens.
The presentation that I did last summer was about a piece of work that I did with a boy with a lot of hospital trauma, and just using therapy to bring joy back into hospital visits for him and his mum and dad, and into their relationship, where parents had to pin him down for a lot of procedures that he's had to have done. And as we were doing the work, he was going to need an MRI scan. And I said, oh, I could turn up when you arrive in the morning. Let me know the date, and if I'm free, I'll come. And I could play some of our TheraPlay games with you as a way of helping him do something that's fun in the hospital that he's got familiar with, and we can see whether that's going to be helpful. So we did do that on that morning, and then the sleepy doctor as we call him, and the anaesthetist came up, and they then took him away and did what they needed to. And I spoke to the mum later in the day, and she said that went the best it's ever gone. And we were reflecting, because it wasn't just down to the bits that I was doing. We'd also had like conversations with the anaesthetist, and that kind of gave the boy a really clear timetable and explanation about this is what happens, this is what happens, this is what happens, this is what happens. But that combination of stuff meant that parents were so much calmer, and he was so much calmer, so that when he went down to the sleep room, that just that going off to sleep was, the mum said that was the best it's ever been.
Wow.
Which for them was just like an amazing outcome to have had. Yeah, and he needed to have them asleep, so we weren't trying to keep him still. There was another young person that I worked with using EMDR to try and help her with the MRI.
So yeah, tell me. I remember, yes, apologies that I've mixed two clients
That's all right.
up, but amazing and yet so obvious that playing helps the nervous system to find a sort of optimum place. And that really key point you've made there about if the parents are relaxed and the parents are relaxed together around the child and are not in conflict or arguing, or one very attentive and one just able to sit back, but that really makes such a difference to the whole atmosphere. And yeah, that little one, yes, he was still going to be put to sleep in order to go through the MRI, but that whole procedure was so much better for him. And then you're thinking about, you've helped me unmuddle my mind there, the other case where you used EMDR. EMDR, if you could tell us what the acronym stands for and tell us a little bit about what that procedure is, because it's a term I often see around, but I'm not trained in that, but would be very interested to hear about this part of your work.
Yeah. So it's eye movement desensitization and reprocessing. And it's a sort of therapy primarily used with trauma and whatever sort of trauma. And it can be adapted for use with pretty much any age. And yeah, the adaptations will vary. And essentially, it is very magical in a sense. Like when you see it happen and you see how it helps the brain process trauma memories, it's absolutely mind-boggling. It does feel like magic. It doesn't feel, it's very strange, but I've seen it work, and I've seen it work so many times. And the kind of the science that is the best sort of understanding that they have around why it works is that it's something to do with filling up your working memory, which is the getting people to move their eyes from left to right, or to do taps, or to move from right to left. So getting a bilateral, both sides of the body movement going, filling up your working memory, whilst then you're bringing to the fore mental images of the traumatic events. And that sort of intention of doing that whilst doing this, somehow that process helps like unconnect all the experiences in the body that have been stored with that memory, because normal memories don't get stored with in technicolor and with full body sensations, whereas trauma memories do. They get stored with all of that, which is why then they come back that they're so overwhelming. And so through the EMDR, you deliberately go into the trauma memories and are basically teaching the body, this is over, it's done. We don't need to hold on to all this stuff in the body anymore. We can let it go.
So
That makes sense.
A sort of, yeah, it's Joanna. That was a brilliant description. So that the trauma memory that feels almost like the past is still in the present. It allows it to separate from being a totally physical experience, like a real reliving, and then store it more as I was going to say a normal memory, and I know that's not the right term, but a memory that might more typically be held within the brain rather than within the whole body. Is that?
Yeah,
that right?
Yeah, absolutely. And I do talk about kind of normal memories, because as a normal or a non-trauma memory, our everyday memories, we can look back and we go, oh, that's a great time, or oh, that was a really tough time, that was awful, I hated that. But we can look back at those might be traumatic memories and go and not have a re-experiencing. We just go, that was awful, I wish that had never happened. That still feels bad. But you're not having that experience anymore.
Yeah, no, that's a brilliant explanation. So then tell us about this client. I'm guessing you call your clients what?
We say patients.
Patients. It's just the setting, isn't it? And in other settings, it will be something else. Service users. That's the one I have to say I dislike. Service users, depending on your context. So this young patient you had that you used EMDR with, I'm presuming that's because he had she beg your pardon, she had some trauma memories about a procedure that was then going to happen again, or not. Yeah, sorry, I'm telling your story. You tell us about this young patient.
Yeah, in the course of her cancer treatments and I guess cancer diagnosis, had some traumatic experiences in an MRI machine, and that then the thought of having MRIs was incredibly overwhelming. She couldn't cope with it. She was managing to have them asleep, but there's an expectation as she's getting older that ideally you do them without having, because there's always a risk with a general anesthetic, and that she progressed towards doing it without, and it was something that she wanted and her parents wanted. So we worked around all the different trauma elements related to that. And she has had an awake MRI. It was still a very difficult experience, but she did it, which was absolutely fantastic. A fantastic achievement, because it's such a strange thing to go in and do. There is a massive sense of threat that's connected with also within what might the results be and all that. So it would be unusual, I think, for it to be a completely stress-free experience. But I'm hopeful that in her future ones, now that she's done one awake and has coped with it and managed it, she will feel more able to cope with the next ones that come.
So the MRI is the one where you're in like a big tube, or part of your body is in a big.
Yeah, it looks a bit like a giant donut, and you're on a bed, and that bed goes in, and then it's making an incredibly loud set of sounds whilst it's taking pictures.
Yeah, it sounds like something's hammering away at you, but it's not. There's no physical pain involved in it, and you need to keep really still. That's been my experience. So how many sessions of EMDR did she have? And is that lasting? Would that be expected to have broken that connection and therefore it she won't have that as a trauma memory anymore? Or is EMDR something you need to keep having top-ups for?
I don't know how many sessions we've had. It's a good question. But yeah, I think once the trauma memory is done, it's done. But you might discover in the process of doing trauma work, or in the process of then going on and facing other things of, oh, actually, there's something that I haven't processed. There might be other things that you realize, oh yeah, that my body is still getting attached to stuff that's not here right now. So I might need to do a bit more work. Yeah, so once it's done, if you've got all the bits of it, and memories are quite tricky. And within EMDR training, they talk about the different channels that memories can go in. There's obviously like your thoughts, the visuals, there's physical sensations, all your, what's the word? Senses.
Oh, your senses. That's the taste, the smell, the touch. Yeah.
Yeah, all of that. There could be bits of the trauma memory in every bit. So there might be things that you might miss and then you come back to. And
yeah.
But generally it is something where it's concrete, we've done it and we do it until it's felt, yeah, there's nothing left in the body when I bring up this memory. Nothing.
Yeah. And it sounds like as you're talking, I can really hear your passion for EMDR. And yeah, I'm a bit envious. I want to go and do that training. I'm running out of time to do any more trainings. But
never too late.
That sense of sometimes the therapy that we do with our clients does feel like magic. Feels, yes, I can explain it in some theoretical term and under a framework and all the rest of it. But sometimes there are those wow moments of, ooh, something's shifted, something's relieved, something's no longer so strong, something new is emerging. And I think in 100 years' time, 200 years' time, they'll laugh at what we don't understand at this stage. I often think I certainly feel I've got a sense of how my therapy works. Makes a difference. But I can't give a scientific explanation for why what I do in a room with a child or a parent, what I do, that there's no sort of blueprint. I can't prove it. I can look at case studies, I can look at outcomes, but I can't actually prove what's happening. But I do wonder when I'm long gone from this world, that my students and their students will be the people who'll go, back in 2026, they thought this. But of course, now we understand that. But we're all part of this continuum of understanding. Yeah. And as you're speaking, I'm thinking about a client a long time ago of mine who he was an adopted child. He was the second adopted child of this parent, single parent. And he had a lot of medical procedures. He had an ongoing medical condition involving one of his limbs. And he had regular transfusions, regular tests and things as an outpatient patient. And my memory of it, and again, I realize my memory hasn't quite proved itself accurate this afternoon, is that he coped with, he accepted, with a bit of a struggle, hospital staff touching him, moving him, putting things in, taking things out, bandaging him up, and all the rest of it. But what Mum was experiencing with him at home, and I think their adoption's journey together started when he was about 4 or 5, was that he didn't want her anywhere near her physically. So trying to do any creaming, bathing, teeth washing, holding his hand, things that physically were not hurting him, They weren't to do with the limb that was damaged. But she found she couldn't cuddle him. She couldn't even tuck him up in bed, give him a kiss. And I remember she came to me as the play therapist in the adoption service I worked with to say, there's something not right. My older child, who wasn't related, another adopted child, is very happy to have physical contact. We cuddle, I tuck him up, I can kiss him, we can hold hands, I can bath him. But now I've got this little one who just says, no, I'll do it myself. And at 5, and you'll recognize this maybe from the world of adoption as well, this little one was all the time saying, I can do it myself. No, I'm fine, don't touch me. I know what I did to work with him, but is that a common thing that happens with your patients where touch, any touch, becomes something threatening or unpleasant?
Yeah, definitely. And it will vary in the different experiences that children across the hospital have. But I've had the great pleasure of being able to train a number of my colleagues in Theraplay, so that Theraplay is getting used in other specialties, not just in mine. But I think within mine, children have so many medical procedures through the course of cancer treatment. There's something called, what's it called? Beads of courage. Come on, brain. Where they get, and it's one of the things the play specialists help with, they get beads for each procedure or thing that they go through. So they can end up with these massive long strings, multiple strings that kind of are a narrative of all this stuff that's happened to them through their treatment. So just the number of things that they have done to their body, you can't comprehend. And so there are changes for, I don't know what the numbers are, but for a number of children in terms of their touch and their experience of touch, their touch defensiveness, how sensitive they are. And it's important for people to be aware of that. And I think it's something when I do therapy with kids on my ward, that I'm so aware of, and talking with parents about, they've had so much done to them, and unpleasant touch, like it's been for a good reason. It's to make them, but actually some of it, particularly when it starts, is very scary. It can, if it's not painful, it's certainly uncomfortable, it's confusing, and it's something that parents have consented to, have said, yes, please do this, child. And often actually are a part of keeping the child still in order for these procedures to happen. And sometimes that for a child to have a procedure, if they need it doing, and we wouldn't ever recommend this, but if they need it doing and they need it doing now, then multiple members of staff will pin that child down to get it done. When a child goes into fight and flight, they are literally like a wild animal, and they have the strength of 1,000 men. So some kids do need, and just imagining like how scary is that for a small person, or even a teenager, of being pinned down, and then that impact on touch. And exactly in terms of, we think about different abuse that children can experience, the brain actually doesn't distinguish between whether it was a physical abuse that came with anger, with aggression, with malintent, compared to a medical intervention. The brain kind of codes that trauma the same. And kids can often then consciously, unconsciously resent their parents and express anger towards their parents, and not want closeness with their parents because they've allowed all this stuff to happen. And just how heartbreaking it is for parents to be experiencing that, because of course they never wanted their kid to have all this happen, and they've had to in order to hopefully make them better. And that real tension, which is why I say to whenever I introduce theraplay to parents, treatments make your relationship wonky. And I'd love to use theraplay to help strengthen and get things back on track. And there's a beautiful family that I've been working with where at the start, we're almost at the end now. At the start, the little boy, he was accepting mum's help with toothbrushing and getting dressed and things like that. But other than that, he did not. Touch was very much on his terms if ever he wanted it. And there was just a beautiful moment through the theraplay work we were doing, the parent review sessions and sharing snippets from the sessions that you've had to that point, of me pointing out to the mum, look, he's come and he's sat on your lap. And she was just like, that was such a powerful moment for her of, yes. And that he has then through the sessions like progressed to be much more comfortable with being and happy being close and snuggly again with her, and also with other people in his network, and happy with me being close as well, somebody in the hospital within the sessions. So seeing the power of theraplay and the use of predictable, structured, thought about touch, that you're tuning into what does feel good to this kid, what doesn't, and learning with the parent as you go along how to help that kid with their touch defensiveness. With this little one, there's things that he does not like, and that's just him. And that's just the way he is. But there's other stuff where we've been able to stretch and expand and help him to feel comfortable with touch again.
And it's that word again that I'm really curious about, because the family I'm thinking about, they had never had it because they'd come to be a family together with him already having those experiences of medical trauma, I think, and never having an experience of mum nurturing him and giving him soft touch. So with that family, they're not trying to get back to something that already existed. It was also strange and weird to him, and so distressing for mum because she so wanted to give that to him. And I'm thinking about, that image, a very vivid image you've given of several members of staff having to pin a child down for some urgent treatment. Does it make a difference if the parent isn't part of that physical holding? Or is it more that the child, and you've helped me think about a new thing there. I was thinking, if the parent doesn't hold the child, then that's going to be fine. But you're saying the child knows that the parent has given consent for these other adults to do that. So does it make a difference? Would you advise that parents are not part of the holding in those situations?
Yeah, you're between a rock and a hard place, I think. And I think the ideal is thinking about it in terms of actually you're not pinning, but you're giving a supportive cuddle. And the ideal to get supportive cuddle is from the parents. So if you might have a big child or a small child, but they're snuggled in facing you, so that you're giving them that proprioceptive input and they're experiencing it from somebody that they know loves them, that's releasing those sort of like calming hormones in the midst of all that stress. And that you can do that in a firm way without it feeling like really traumatic, and that by holding them this way, then there is access to arms over this side or feet or whatever, because normally the procedures, it's cannulas, that having the little needles and tubes, that's what is most distressing for children. That there's more safety, a sense of safety within that if parents can give them a cuddle. Some parents are so overwhelmed themselves, they get so anxious themselves that doesn't help. So sometimes thinking about the positioning of that is that that is a safe place being like this, even though something disturbing, distressing is happening, compared to if you're laid on a bed and people are pinning you back like that, you're so vulnerable, like physically, it's so vulnerable. That is so much more traumatizing to the body. I think. And it's tricky because you don't know how your child or you are going to react until you're in that situation. And once you've had a traumatic experience, it is then hard, not impossible, but it's hard to do something different. So there are various things we keep thinking about within our hospital about how can we do this? How can we try and minimize the trauma for the children that come into hospital? Yeah.
But as you say, if you
exciting.
but you won't know. Often you'll first meet them when already some of that trauma has taken place. If you'd already been working with the child in some sort of therapeutic way for a year before their cancer diagnosis and treatment, you might have a really good sense of actually what goes well for this child and what doesn't. And I'm thinking about your patients who are neurodiverse. Is there anything in particular you bear in mind? I'm also thinking about neurodiverse parents and their needs, their way of understanding and approaching touch and trauma and medical procedures.
I was just thinking about the like touch and trauma, of thinking how there's an extra level for kids who are neurodivergent that we coming into hospital, that those of us that aren't neurodivergent wouldn't find traumatizing. That it's not just the touch, but actually like the sensory overstimulation, the beeps, the number of people, lots of people coming that they should say their names and who they are, but people don't always in a hurry. And when there are so many, you can't remember who they are. And when your body or your parent, you are unwell and stressed anyway, that there's so much that is overwhelming sensorially, that it's helpful to try and be aware of those. And I think our hospital is aware. Obviously there's always things that can be improved upon, and there are hospital passports for kids where that there are particular things that they are triggered by, or particular things that help, that then can be in a document that staff can see. And then there are quiet spaces that children can have access to. Or in terms of our work, I think we're always very much trying to tune into that individual child, that individual family, and in that way picking up on what is particular to that particular neurodiverse child or parent, and thinking about how we support them. And there are people within our wider team who are far more experienced with working with neurodivergent kids, young people, than I am. So then I always go, we've got that opportunity to talk to other people and gain wisdom from other people, how best to support. Does that sort of answer the...
Yeah, it does. And as you're describing your hospital and even the concept that you have a team, and I think it's about 30 people in the wider team. Is that right? In the psychology?
Actually, I got corrected this week. Not corrected, but told actually we're about 45.
Wow. So
Yeah.
And that's the psychological service within the children's hospital.
Yeah. So we've got psychologists, CBT therapists, family therapists, psychiatry. I'm hoping that I've not forgotten anybody.
Have you got any creative arts therapists?
I'm just about to have somebody start on placement as a trainee, which is our first person. Actually, there was somebody when I started like 13 years ago, and I don't know how long she was in post, but since, and what kind of happened to her post, or whether it's charity funding or whatever, I'm not sure. Yeah, there was somebody like 13 years ago, and all that time we've not had anybody else.
So I was wondering how a play therapist or an art psychotherapist, drama therapist might also fit into that team, especially at the processing stage. As you said, there's the in hospital receiving treatment. There's a huge part of that work, but then there's also the coming back a year later, 10 years later, 15 years later, to think about, to process, to be with those memories of perhaps when you were younger and had procedures. And it's interesting, as you're talking, I'm thinking I had some surgery last year, knee surgery last year. So in my 50s, I had some surgery. But I found that almost immediately I was given the letters about this is your appointment day, this is you're going to see the anaesthetist. I was right back to being a teenager when I had lots of operations as well. And it's suddenly 40 years later caught up with me. And I was so shocked by it. And actually, they were very helpful. I had woken up in an operation. I had woken up in mid-operation. And I went to see the anaesthetist team. They were very understanding. They said that doesn't happen anymore, or it shouldn't happen. And if it does, we'll do this. And actually, but I was so surprised by how I was suddenly back to being 14 again, 15 again, when I'd had what I see now as traumatic experiences. And how wonderful it would have been to have somebody like you around. On the adult orthopedic ward that I was on as a teenager, there was no such thing as a children orthopedic ward. You were just stuck on the end of, on the male surgical ward. So it's like, what was happening? But I was so surprised that many 40 odd years later, how my body just couldn't even go into the hospital to go to these appointments. I did a lot of it by phone, and then eventually I went into the hospital and I knew what was going to happen, and they talked me through it. And I can really understand that what happens still in the body many years later. Joey, we're coming towards the end. We've probably got 5 minutes left. I just want to ask you this question. I think it just because I hear it, things happening, and it bugs me, and I don't know quite why it bugs me. A sense of when a child or an adult is in hospital, often the phrases I hear, or even hear myself saying, is, "Aren't you brave?" Or, "You're a really good fighter." "Oh, well done, you got through that," and "You're just a brave little soldier." What's your thoughts on that sort of language? It grates on me, and I'm not quite sure why, but that sense of you need to be brave and grit your teeth, and aren't you a fighter? And when you're in hospital and you're feeling awful, I never wanted somebody telling me I was brave. It hurt and it was scary, but nobody ever said that. So I just want to get a sense from you about the language we might use around anybody who's receiving treatment.
Yeah. And I think you're absolutely right. When you're on the receiving end of it, you're like, and sometimes kids have said to me, "I don't feel brave. I don't have any choice about whether I'm brave or whether I fight it. This is just what I've got to do." And there is that sort of indignation. It's like, "Ah, why are you telling me this?" But we do it because we're trying to, those of us at the outside, we're doing it because we're trying to be encouraging, aren't we? And we recognize that there is bravery. And I actually think of a young person I worked with the other day where actually we were installing a positive belief around, actually, I am brave. I can do scary stuff. But that was something that she'd chosen to identify with rather than, "Oh, aren't you brave?"
Yeah.
Of that, which can come across as quite kind of patronizing. And that actually the intention isn't to be patronizing or to upset the person anyway, but the experience on the receiving end, that isn't, it doesn't feel nice. So thinking about what you could say instead, I think it's what you've said of acknowledging, "Oh, you're having a tricky time, aren't you? This is hard," or how can I help you today? What would feel good today? Or
Yeah.
Not ignoring it, acknowledging
Yeah.
that this is tricky, also not like dwelling on it and, oh, that poor you, like seeing them, like the otherness of them that's not their illness.
Yes.
I
Yeah.
think that's one of the things that young people often say around their cancer diagnosis. Partly I don't want to tell people because I don't want them to just see me as the sick kid and treat me differently. On one level, I do want to be treated differently because I have got stuff going on, but equally, don't see me as weak. Don't see me as, or don't see me as the fighter or whatever. Just see me as me.
Yeah.
I'm me.
Yeah. And get to know how as like you did with your young person there about the word brave. Get to know how that young person is seeing themselves, help them to get in touch with actually what they are feeling, which is a huge part of what we do in therapy, is sit with the difficult stuff and begin to give it names, begin to give it stories and symbols that can help express something that just feels ugh or ugh. It just has a sound perhaps, but begin to give it a voice so that we can then do something with it. And that doing something with it might just be sitting with it and saying, you're really sad today. You're really sad. And that feels rotten. And we're having macaroni cheese for dinner. All of those can be held together. But it's that often I've heard children where they're, and I experienced myself as a young person, yeah, aren't you brave? You're a good girl, you've made it through this, you're a fighter, all of that. And actually it didn't feel any of those things, but because nobody around me was offering any other words, I don't think even for myself, I thought even that I could be sad or upset or in pain because nobody was offering that as an option. And yeah, so I will think hard about what I say. I suppose in any situation with any other human being is, yeah, you seem to be having a tough time today. Or I might have got it wrong, but oh, that looks really painful. But it might give the option that my view isn't the view that they need to hold. Yeah.
Yeah.
Gosh.
And I was thinking, it's just tapped me one moment into thinking about at the end of treatment and when treatment is done for our kids or young adults, or even the parents themselves, when people say, oh, aren't you relieved it's all over now? It's all done. Isn't that good? Or just look at the positives. Isn't it? And actually that it grates with people that have experienced it because it's not actually over. There's long-term, lifelong repercussions of stuff. And for people to say, aren't you relieved? It then shuts down the possibility of sharing the people's lived reality of actually there's still hard stuff there. Yeah, there's loads of stuff I'm relieved about, loads of stuff that's great, but there's still hard here. Like you were saying, actually having things open rather than making assumptions about how somebody feels or what their experience is, having offering something and then giving them space to go, actually, no, that's not right. Oh, yeah, that is.
Yeah. And to not shut down their options for what they feel about where they're at with treatment or recovery or there isn't ever a moment where everything is over. The stages where bits are over. But whew, Jo, I could talk to you for hours, but we've run out of our time for this afternoon. I'm so grateful for you for giving us an insight into what happens at Sheffield's Children's Hospital, and delighted that there are 45 people in your wider team to work with the families. So we'll say cheerio for now, and thank you for listening to this episode of Pondering Play and Therapy. Thanks, Jo.